baby. B for BP. Baby means pregnancy and PeriPartum CardioMyopathy. So PPCL. So let me start by getting some of the questions. According to the question-based approach, we already focused on to the main question, my dear. So what is the main questions? Yes. So what is the most likely diagnosis? What is the most likely diagnosis? The PPCM, that is a PeriPartum CardioMyopathy, idiopathic dilated cardiomyopathy, infarctive endocarditis, anemic heart failure, and viral myocarditis. These are the options. So you need to focus immediately after that the answer options to think of the SS boxes that you learned from the video lectures and also the KBA lectures. And after that, you need to focus on to the main photography, what the photography is. So here is one photography here. So this photography gives you the idea, the dilated atriums and also the ventricles, the apical four-chamber view of the echocardiography that shows the dilated cardiomyopathy. And also this is also the plaques view we called that showed that the parasternal long axis view that shows once again the dilated left ventricle once again. So yes, this is the dilated cardiomyopathy. And once again in the ECG shows some of the big complexes. Yes, in the V2 is the deep S and V3 is the deep S webs. So V1, V2, V3 deep S webs. Some of the features of ECG abnormality that you have seen, we'll discuss more further. All right. Here is the dilated, yes, once again, the dilated cardiac shadows and with the pulmonary edema. So once again, dilated cardiomyopathy possibility. And immediately after the photographs that you can, yes, look at into the data. So here the differential diagnosis, the PP7, idiopathic DCM. So my dear, before going to the, yes, the photography that we can focus on to the investigations that the blood cultures are awaited, WBC counted, bit raised, arterial blood cases, that the WBC 12, these are important, and also the pH 7.40, partial carbon dioxide 4.2, and partial oxygen 7.4. So yes, partial carbon dioxide is a bit reduced, but the pH is normal and bicarbonate is, yes, 22 to 26. So a bit of abnormality is the partial carbon dioxide is, yes, reduced and partial oxygen is reduced. So what else the data showed that here, and the investigator see the hemoglobin 10.2, WBC once again 12, platelets 354, ESR 32, and CRP is 12. What the examination findings? On examination, the pulse was 112 beats per minute. The temperature was 37.2 degrees centigrade. The blood pressure measured 110 by 65 millimeter mercury. JB was raised. Palpation of the precordium revealed displaced and prominent apex. Displaced and prominent apex, it does mean the cardiomegaly. Monoscaldation of the both heart sounds were the normal. In addition, there was pansystolic murmur. Pansystolic murmur. And A3 means the left ventricular failure, and pansystolic murmur is due to the dilatation of the ring of the mitral valvular ring. So it can cause the pansystolic murmur. Auscultation of the lungs, there is the crackles. Once again, the left heart failure. And next to the history, so let's see, the 28-year-old lady, primary gravida, complained of 10 days history of increasing shortness of breath, orthopnea. So orthopnea is a heart failure. Paroxysmal nocturnal dyspnea, yes, the heart failure. Once again, with a past medical history of the LUCS. The cesarean sections for an uncomplicated twin pregnancy 3 weeks previously. Yes, this is important. Our BP recording showed the normal throughout the pregnancy. My dear, listen very carefully. A lady with the pregnant lady and delivered a twin pregnancy. So my dear, is very important that the last month of the delivery, before the 1 month before the delivery, and 6 months once again after the delivery. So this is called basically the PeriPartum cardiomyopathy. So what we say that immediately after delivery, if the lady presented with the shortness of breath as well as the orthopnea as well as the paroxysmal nocturnal dyspnea, the first diagnosis we should think about the dilated cardiomyopathy, but this is due to the peripartum, or we can say the postpartum cardiomyopathy. So here's the diagnosis here. The patient has noticed increasing dyspnea, swollen ankle just prior to the delivery, but attributed to her advanced pregnant state. Yes, it happened prior to the delivery, so it's peripartum or prepartum, we can say. A murmur was heard on the routine examination in the second trimester, with the investigative ECG, echocardiogram that were both reported as normal, with no family history of the other cardiac diseases. Sometimes it's the multivalvular heart disease, sometimes the rheumatic valvular heart disease also. The pregnant lady can flare up heart failure during the time of pregnancy, but in second trimester is not a case, of course, a case of dilated cardiomyopathy. So peripartum cardiomyopathy is 1 month before the delivery and 6 months after the delivery. So all them together, the diagnosis of the peripartum cardiomyopathy is likely. So let's see what explanation says that the patient presents with the pulmonary edema in a pure period, as with the systolic heart failure. She had previously documented normal LV function, and there is no obvious cause for heart failure other than pregnancy. Yes, this is very important. She had previously documented normal LV function. Documented normal LV function. Although she had a low-grade fever, murmur, or mitral regurgitation, and CRP not high enough to indicate overwhelming sepsis, and in echocardiogram it doesn't show any of the vegetations or valve dysfunction as would be expected in this situation. Peripartum cardiomyopathy affects 1 in 3,000 live birth pregnancies. The etiology is unknown, but the condition is much more common in African women after the other predisposing factors, including the advanced age, multiple pregnancy, multiparity, or a history of the hypertension in pregnancy. So it's a very good diagrammatic picture. So the probable risk factors and also some of the proposed risk factors. The probable risk for twin pregnancy, high parity, high gravity, extremes of reproductive age, and prolonged tocolysis. And very important, the emerging risk factors are preeclampsia, genetics, and obesity. And proposed risk factors: smoking, hypertension, malnutrition, cocaine abuse, African ancestry, and also socioeconomic status. The condition presents within the last month of the pregnancy, within 5 months, but is said that within 6 months post-delivery, whereas the females, idiopathic DCM present in the second trimester when the burden of the volume overload is greatest. Diagnosis requires the following 4 criteria: presentation in the last month or within the 5 months, but it said the 6 months. All right. Absence of an obvious cause for the heart failure, previously normal cardiac status, and echocardiography evidence of systolic left ventricular dysfunction. So these are the diagnostic criteria of the PVCM, that is heart failure within the last month of pregnancy or 6 months postpartum. Absence of the prior heart disease, this is one of the important criteria. Absence of the prior heart disease and no determinable cause. So the most important peripartum is that pregnancy related. So there will be no previous prior heart disease. So echocardiographic evidence of the left ventricular dysfunction, that is LV ejection fraction less than 45, and fractional shortening the less than 30%, and LV end diastolic diameter less than 2.7 centimeters square meter body surface. At least you must remember LV ejection less than 45%. The patient fulfills the 4 criteria. The ECG may show the multiple abnormalities that includes the voltage criteria for the LVH and STD abnormalities in this case. So a bit of voltage criteria LVH, and there are no symptoms of marked ischemia as expected in thrombotic marked infarction that may rarely complicate pregnancy. The management is with the conventional heart failure therapy, like the ACE inhibitors, should be avoided during pregnancy. Patients is very dilated or poorly contracting left ventricle should be anticoagulant, as the risk of intramural thrombus is high in peripartum cardiomyopathy. So the treatment that we put at numeric smiler, you must make your own notes, right? 2D and 2H. D for diuretics and digoxin, and H for hydrolyzin and heparin. and we add 2 D's more. There is a dilol, there is a carvedilol, and D for dopamine receptor agonist like the bromocriptine. So once again, diuretics, digoxin, heparin, and hydrolazine, and dilol as well as the dopamine receptor agonist. So what I say, the diuretics, digoxin, hydrolazine, heparin, dilol as well as once again bromocriptine or as well as the dopamine receptor agonist. Some of the peculiarities in the management of the acute heart failure caused by PBCM: multidisciplinary approach with a focus on health of mother as well as the fetus. Avoidance of the heart failure drugs with fetal toxicity during pregnancy like the ACE inhibitors. These drugs, right, is very important, and is a aldosterone antagonist, and breastfeeding. Thereafter, standard heart failure therapy. Consider the bromocriptine. Yes, 2.5 mg twice a day for 2 weeks, followed by 2.5 mg per day for 6 weeks, in addition to standard heart failure therapy. So bromocriptine has a role. Anticoagulations with the heparin to avoid the cardioembolic complications in patients with the LV ejection fraction less equal to 35% are treated with the bromocriptine. So yes, my dear doctors, heparin should be added. In this case, the cardiogenic shock. When there will be the shock. Consideration levosimendan. So my dear, just say with me, levosimendan. Instead of catechol as a first-line inotrope drug, early transfer to experience center, and early evaluation of the mechanical circulatory support according to the center's experiences. Prevention of sudden cardiac death, early consider the EICD if the patient LV ejection rate is equal to 35%. So yes, my dear doctor, so there are the important things that ACE inhibitors in ARBs and aldosterone antagonists should be avoided, and B for once again should remember the bromocriptine should be added in standard therapy for the heart failure therapy, and also anticoagulation, there is a heparin should be added, and once again the shock, the levosimendan that we need to remember, the first line inotropes. So if you say the ABC, so that may be helpful to remember. So once again, A for ACE inhibitor, ARBs and aldosterone antagonist should be avoided. B for bromocriptine should be added, and C for coagulation means the heparin should be added. And once again, if you write down, that's really important, right? So this is the cardiogenic shock. So C for cardiogenic shock. So levosimendan. So if I'm saying the C-mendan or levosimendan, that will be helpful to remember all them together. So A, B, C. A for ACE inhibitors, ARBs. B for bromocriptine issues, and C for coagulation, and C for cardiogenic shock. At least these 3 important things that you need to remember. The prognosis is guarded with up to 25% females dying in the first 3 months. Approximately 50% recover full cardiac function within 6 months. Around 5% of females recover of cardiac transplantation. Future pregnancies should be avoided in females who haven't recovered the normal cardiac size and function. Some of the oral pharmaceutical therapies like the beta blocker, vasodilator, digoxin, and diuretics, so you need to look into them. And some of the initial evaluations, right, assess the cardiopulmonary distress and confirm the diagnosis that the severe PPCM with the cardiopulmonary distress and PPCM without cardiopulmonary distress. With some of the distress that optimize preload, that is the volume versus diuresis vasodilators, optimize oxygenation, add inotropes. One of the important things, the distress, I mean the levosimendan, just say with me levosimendan, that should be added in the first line inotropes, and the urgent delivery, and consider bromocriptine, consider mechanical circulatory support, recovery, transplantation, weaning. And these weaning means the patient is stable, that the without cardiac distress. If the patient do the antepartum, means before delivery, heart failure therapy can be given the standard therapy, but the ACE inhibitors should be avoided, like hydrogen nitrate instead of ACE inhibitors, and beta blocker, and also the considered diuretics. In contrast, the postpartum, yes, we can use the ACE inhibitors, ARBs, and also the spironolactone, and also beta blockers and diuretics, and consider ivabradine as well. So yes, both cases consider delivery, antepartum consider delivery, And postpartum case, they consider bromocriptine is really important, and consider once again the wire cardiovascular defibrillator therapy if LV ejection fraction less equal 35% and continue heart failure therapy. So acute heart failure during pregnancy, how it can be managed. So status and prognosis of the fetus is really important, and fetus non-viable is delivery. Fetus viable, patient with the maternal and fetal status, delivery, and pregnancy continued. So that can be very easy. So yes, my dear, this flowchart will be really helpful, and we'll have the video lectures as well, right, so that you can understand what I'm saying. Some of the SS boxes will be also given to manage the PeriPartum cardiomyopathy. Here is also the history. If it is says that the heart failure symptoms onset in the last few months of the pregnant, first few months of after delivery, no previous history of cardiac disease. If the answer is yes, then go for clinical examinations. And once again, if not something like so, consider alternative diagnosis. Clinical system, the signs of systolic heart failure. If it is not, then consider alternative diagnosis. Next, go for if the patient is normotensive or hypotensive or hypertensive, so consider the preeclampsia. But if the hypotensive, once again normotensive, the transthoracic echo, that will give us less equal 45 and more than 45. So more than 45% is consider alternative diagnosis, but less equal 45%. We need to do some of the chest X-ray labs and also the ECG to exclude and also for the management plans that are really needed. So adjunct studies, the cardiac MRI useful when echo images are non-diagnostic, may provide the prognostic information. Right ventricular biopsy useful in patients with ventricular tachycardia or high-grade heart failure in patients who fail to respond to the optimal medical therapy. Yes, my dear doctor, somebody talked, right, that you need to work on the systolic heart failure, hypertension, that should be excluded before diagnosing. Yes, of course, PeriPartum cardiomyopathy. And the most important thing is less than 45%. So three important factors, right, that systolic heart failure, hypertension, and LV ejection fraction. If it is more than 40%, if any of the patients, so there is less likely a possibility of PeriPartum cardiomyopathy. So three things that you need to remember. Here is a ECG that is given like ischemic cardiomyopathy. Some of the features of cardiomyopathy. There is a marked LVH with the dominant S wave in V1 to V4, right axis deviation, such as this with the right ventricular hypertrophy. Yes, there is the right axis deviation. You see the 1, 2, 3 having the dominant R wave, the negative R wave, there is the S dip, so the right axis deviation. There is evidence of the left atrial enlargement, like the deep white terminal portion of the P waves in the V1. So look at it at the V1. Yes, there is a deep. So this is very rarely found. So this is once again the left atrial enlargement, and there are picked P waves in 2, so it's the right atrial hypertrophy. So yes, not quite 2.5 millimeter in height. So in lead 2, you see the picked P wave. So once again, picked P wave, P pulmonary. So there is the right atrial hypertrophy. Once again, the V5 phasic. Yes, maybe you can say the wide P waves. So wide P waves once again, case of we sometimes call the P mitrally, so left atrial enlargement. So biatrial enlargements along with the left ventricular hypertrophy, so a possibility of cardiomyopathy, dilated cardiomyopathy. So here is an echocardiography. Once again, can shows that all the chambers of the heart are dilated, so there are the dilatations. So these are the references. I hope that, my dear, you got the PeriPartum cardiomyopathy, the exact idea, and the management plan in details. So it will be really helpful. There's this boxes all them together along with these KBA lectures. It will be really helpful. I hope that you enjoy. Thank you very much, my dear. Thank you once again.